Okay, thank you very much, everyone. I'm going to talk about oxygen therapy. Thanks for the two fantastic presentations so far. That's hinted around oxygen therapy. You can see that it's going to be a vital part of management of ILD. I am going to talk a little bit, I'm not going to spend too long on evidence base at the top of the talk, but essentially there's a few papers around oxygen therapy. We'll go into the assessment of oxygen for patients with ILD broadly. It's not just IPF, but I'll be talking about the IPF group as well. And then we can talk about the actual practicalities and the real world of oxygen therapy with IPF. So the next couple of slides are just for those of you who just want some evidence base around or some titles to go and look at after this talk. This is really useful, evidence so far. So you got the European Respiratory Journal 2017 systemic review around oxygen therapy for ILD. So that's also quite a useful document to read with exercise and oxygen and whether it had any effect on breathlessness. And you'll find a similar theme throughout a lot of these papers around the fact that it doesn't necessarily reduce the breathlessness that patients feel, because obviously the underlying lung disease is pretty poor and therefore they will still feel breathless. Oxygen isn't a cure for that, which again is the management of expectations around oxygen therapy with ILD. But it can improve your exercise capacity. No significant impact on mortality, but also a lot of the guidance around oxygen, especially long-term oxygen therapy, is taken from COPD principles and applied to ILD, which is obviously not the true group, but there's not as much evidence base around ILD. Cochrane reviews, not surprisingly, in this patient group are few and far between for randomized controlled trials, and that didn't particularly have any benefit, but clearly, that's just if you do a evidence review. We've got the 2015 BTS home guidelines that I'm sure everyone is very familiar with. The recommendations in ILD clearly is still around the same principles of LTOT approach to patients. So this is just a quick recap, if you like, where you need to be clinically and significantly hypoxemic at rest with kilopascals of 7.3 or below or above or 8 if you've actually got secondary issues. The palliative oxygen therapy concept is for severe breathlessness if you've tried everything else. Careful patient choices there. And obviously the aim of oxygen therapy is to keep somebody above 90%. Now, again, people have this thing around oxygen that they probably need to take some time off. You don't need to take time off. In fact, your outcomes are better if you don't. So 24 hours a day do better than the minimum of 15. But obviously that's psychological to patients and they may feel that they don't want to be tied to the oxygen. Anyone who needs oxygen to sit still will clearly need oxygen to walk about. In fact, they'll need more oxygen probably to walk about. So anyone who's LTOT, you should be considering ambulatory assessments on. Now, I have a little bit of an issue with the bottom statement with the BTS guidance, especially when it comes to the IPF group, because obviously ambulatory oxygen is therefore meant to be used for walking, and walking is therefore deemed to be only outside your house. Now, clearly that's not the case, and especially in this patient group where they are extremely limited at the end stage and walking about the house is their exercise capacity. We need to be looking at how we actually support that at home. The American Thoracic Society in 2020 has got something more updated and more recent. It does include ILD. Similar things around LTOT, that's not particularly different really, although there's a slight difference really around only moderate hypoxemia not getting LTOT, which is interesting. But read the guidance, it's actually quite an interesting paper. When you start talking about ambulatory oxygen, again, it reinforces that for severe exertional desaturation. Liquid oxygen should be provided. This is America where they have a lot of liquid oxygen. But if you're dealing with IPF and you're not prescribing liquid oxygen, you need to have a serious think about what you're doing, because it is one of the only options available for very high flow rates that is practical. However, patient selection is also key here. So more than 3 litres, we should be thinking liquid, and education, obviously, around patients and carers. So what do patients say about oxygen therapy for ILD, which is really interesting. And the 2 papers I've quoted here pretty much say the same thing, but the top paper, I put the bullet points into it, which I thought were really good, actually. So this was looking at LTOT and ambulatory for ILD patients. Oxygen naive patients expected it to help their breathlessness, but it didn't, as much as they thought it would. Most patients did report physical health benefits of energy levels and activity, which is what we want to happen. However, using oxygen did, and Sharon alluded to this, around the fact that it's fear of disease progression, there's stigma around it, it does limit their freedom, they're worried about whether it runs out, so they therefore then stay at home because they don't want to go anywhere. And some of that may be because we're not giving them the right equipment. And obviously variable approaches to how they use it. Some people use it as they should, which is continuously. Some people only use it for a quick burst of oxygen once they've actually gone up the stairs or something. So clearly education is very key here. And the portability of the equipment is important. So there's 2 aspects to oxygen ambulatory assessments for me. Obviously, long-term oxygen therapy is based on blood gases, and that's to assess the degree of hypoxemia. For your typical ILD patient, we're not really worried, and Rama said it herself, it's the CO2 rising. So clearly, usually with oxygen therapy, we're just looking at how low their oxygen is. Rather than titrating the oxygen that way, we're not particularly anticipating any high degrees of CO2. I think once you start to hit elevated CO2s with ILD, you are in very end stages because you clearly are not ventilating at all at this point, and it's getting very much worse. So the ambulatory oxygen assessment part, there's a science aspect and then there's the life aspect. So I think there's 2 parts to it. The science is quite easy, although laborious. Walking test, 6-minute walk test would be typical. To do it properly and scientifically, you need to do 2 because you have a learning effect on number 1. Those need to be both on air. Then you do the next one on oxygen, and so it goes on, and you choose the oxygen that you're going to do the second test on. And if that's not good enough, you need to do another test, and you need 20 minutes between each walk. So an ambulatory oxygen assessment test can take a very long time if you're actually trying to do it properly. So, it is laborious. The endurance shuttle walk test is where there's some evidence around how much oxygen you might be able to titrate given a degree of desaturation. But the endurance shuttle walk test is only after you've done 2 incrementals. So again, practicalities here. 6-minute walk test distances should be over 30 metres, not the usual 10 that we do, but pretty much everyone does a 10-metre course for practical sake, but it's not ideal. And you're looking at Borg and frequency of resting and the duration of how long you've had to rest for to give you a total distance at the end. And I think we know that the saturations need to drop by a level of 4% to get to below 90% to qualify for ambulatory oxygen. So that's just a quick run through the science part. How much oxygen do they need? And we know that with IPF and certainly other ILDs, the reason they desaturate clearly is their diffusion is impaired by the disease process. But what's made it even worse is when you're exercising, your cardiac output is high, the blood is circulating through your lungs at a higher speed than it is at rest. So if you can't even put it across into the bloodstream at rest, when the blood is flowing much, much faster through the lungs, it is leaving the lungs without its adequate oxygen with it. And that is so much more exaggerated on exercise than it is doing nothing. So some of these patients may just get away with, 2 to 3 litres to sit still, but may need 6, 7, 8, 9 litres when they're walking. And clearly then we have an issue about how do we provide that. So it is difficult. This flow, this chart, if you like, was based on endurance shuttle walks and whether you can predict if they desaturated to X on the left, how much would you start at? And I think some of this really is practical advice. Now, the lower they go, you're not going to start at 1 litre of ambulatory, you'll be starting higher. So someone's done the evidence and put a little bit here to guide you as to what you might want to start your walking tests on. So does desaturation matter? A lot of people are very worried about people desaturating, especially in pulmonary rehab classes and life, because they think they may well get an arrhythmia and die. That would be a worst case scenario. Interestingly, some of the evidence around that is not the case. A lot of these patients have been doing this their whole time, and they're still alive. So there's no more adverse events with desaturation in certainly the ILD group that desaturated to less than 80%. And so I think from a, maybe from a security point of view, from a clinician, you're not as worried. It doesn't happen really. Clearly they're very breathless. It's very scary. But as Sharon said, you're sort of sitting there watching someone with SATs of 48. They're still breathing. They're scared and terrified, but they're not having an arrhythmia.
Couple of minutes summary.
Okay, so the life part is basically the patient. Are they going to use it? Should you use it for a trial period? What sort of equipment are they going to have? How frail are they? Could they cope with the equipment? And smoking is always in there with oxygen therapy. I'm going to go a bit further on about what sort of choices we've got. So for your standard equipment, we do have the concentrators that everyone knows for 24/7 therapy. For ambulatory, you've got cylinders, the portable concentrators, which tend to have the pulsed options, and the liquid, which has pulsed and continuous options. You've got your extras and things like that you can use for portability. But the special equipment, which is what Sharon was talking about, was the high flow oxygen therapy. I'll come on to a little bit in a minute. And obviously things that you may not need to worry about, which is around cost and delivery. But having a look at the cylinders, your flow rates vary from 0.5 up to 15 litres. To think about how long that's going to last you, it's variable. So it's less than an hour and a half if it's on 6 litres a minute. I don't think conservers with patients who are very breathless are useful at all. In fact, it slows it down because your trigger for that bolus of oxygen, because that's what a conserver is, it's a trigger sensitivity. Your respiratory rate is usually too high, and the delay in receiving the bolus, which I find causes further desaturation. Multiple cylinders will probably be needed if you're going to have a very active person, and we want them to be active and fulfill their life, which requires fill-ups and things. Liquid oxygen, three flasks, sizes of flasks, small, medium and large, and they therefore can hold more liquid and can therefore give you longer durations of liquid oxygen as it evaporates. It does do pulse, but I said I personally don't find pulse that useful really. And the largest flask is for people who need high flow rates over 6 litres. So if you're going to need more than 4 litres a minute of constant oxygen at home, what's your option? Well, clearly concentrators are pretty much the only thing that's going to be able to supply 24/7. You can get high flow concentrators that can be 8 litres up to 10 litres per concentrator, but you may need to piggyback 2 together into a mask. Therefore, you need to consider space and housing and things like that and the usual safety aspects. Non-rebreathe masks at this point are going to be required if you're needing that high flow rates. I have a thing about Venturi masks with these patients because Venturis are great when you're looking at acutely ill patients and you want to know exactly what oxygen percentage they're getting. But because of the Venturi system, the exit flow rates of flow of gas to patients is actually far less than their inspiratory need. So they start to dilute it with air. I've got a chart coming up in a minute that will probably make that clearer to you. So the higher the Venturi 60%, the lower the flow rate exit from that valve, and therefore the higher dilution that the patient will breathe air with, and therefore potentially they'll desaturate more. So, and humidification is an issue. I've talked about the trigger sensitivity varies between each device as well. So the actual profile, the ease of triggering, the bolus profile, the rise time of each bolus is different between each device. So that's why you need to try the devices with each of your patients, because one might be better suited than another. And the Venturi slide is this one. So if you look on the blue at the left, this is the flow rate that you put up the barrel of the Venturi valve. You've got the 24% mask, so let's have a look down. So 24% Venturi mask, you can put it at 2 litres or 4 litres. At 2 litres, 51 litres a minute exit that valve. And at 4 litres, 102 litres exit that valve. Patients who are very breathless will be breathing, quite happily, probably 40, 50, 60, maybe even higher than that. So they need to be matched by the flow rate coming at them, in which case they won't dilute it because they're getting what they need from the valve itself. Flick over to the 60% valve on the right-hand side. 12 to 15 litres driving gas up the barrel only gives you 30 litres flow rate coming out of that barrel. Patients will be breathing 60 litres a minute. They will be diluting that oxygen down with air. And as much as you think you're giving 60%, the patient probably will be not getting 60% oxygen by the time they've breathed it in, which I think as well is the gap where the Optiflow is really useful. So this is just a picture of the oxygen devices that you can have for home. Clearly you've got your concentrator in the middle there. You've got your portable equipment, and over to the left is somebody who's got a liquid oxygen dewar system in their house. That's the size that it is, and the flasks are on the top of that picture, and you need to be able to fill them up yourself. So there's dexterity and capability of using liquid, but it really is fantastic for patients who are active and mobile, who need high flow rates. The other thing is about Optiflow. Sharon's talked about that already. You've got that fantastic photo of a gentleman who's in St Hospice at the moment, St Francis. So we can now do it at home. I know that's in a hospice, but our oxygen provider will do that for you at home. But again, your home environment needs to be built for that, and we're still trying to work out what that patient group might look like. It does need 3 concentrators, so you need to have space for that amount of equipment. It is continuing care funded, so it's not on the BOC or certainly your oxygen provider's contract. It's outside of that contract where you need to get extra funding agreed. To try and do the process of paperwork to actually get that sorted out in time to get this, especially if it's palliation, can be defeating, but it's still worth trying to do it. And the outcomes, as Sharon said, have been impressive. And so this again is a picture similar to what Sharon had, but this is just off a website really. What you do have is it produces 60 litres a minute of pure oxygen. So again, you're looking at high oxygen concentration, high flow rates, warm, humidified oxygen, which means it's very well tolerated, even at very high flow rates like that, and therefore their palliative symptoms are so much more addressed by this. But clearly it's not portable. This is for somebody who's probably bed to chair or very within one room living, because it's not something that you start wheeling around the house. And the cost isn't yours. The cost is then charged, if you like, with that continuing care funding application. Thank you.
Thanks so much, Maria. That was fantastic. I wonder if there are any questions, as I know
recording stopped.
You need to head off shortly, so let's just see if there's any questions. Thank you so much, Maria. I think you covered such a broad spectrum from what we use oxygen for, the assessment process, and then the vast amount of equipment that there is available. And I guess it all depends on, we use BOC in our areas, but there are other oxygen providers in different areas of the country, aren't there? So I wonder how much variability there is in terms of, like, does everyone have Optiflow, for example, or is that?
No, I think you might need to work that one through with your provider, but certainly I think if you've just got your standard equipment, if you're dealing with ILD and you're not looking at liquid and cylinders, if you're just providing portable concentrators, which are fine for people who maybe ILD is not that severe, pulse flow may be okay. cups of tea, outside shopping.
Recording in progress.
But otherwise, I would be looking at something that gives a little bit more punch. Otherwise, you're kind of not giving your patients the right deal, really.
Yeah. So it's really learning about what's in your area and linking in, like Sharon said earlier, finding out who your respiratory teams are and using their expertise to provide the knowledge and then the help with the resources.
Yeah.
Okay, right. We've only got time.
Do you have a question, Sharon?
Yeah, we've got a couple of questions and then we need to move on. So Sharon.
Thank you, Maria. That was fantastic. Really, really interesting. I know we share views about having to be pragmatic with pulmonary fibrosis patients, and I've done all sorts of things like suggesting to people to give their noses a break with high flow oxygen through nasal specs, actually putting the nasal specs in their mouths sometimes because they can't tolerate a mask and they can't tolerate the high flow through the nose because it's bleeding and crusty and so on and so forth. So I think with high flow oxygen through nasal specs, they do need they often need a break just to give their noses stop their noses from drying out. And you can get dryness and crusting, but you can also get a pouring nose. Quite interesting. That seems to be very individual. I just wanted to very briefly say about Optiflow. It's new. This all came from COVID, and it is an amazing piece of kit. But my goodness me, Maria is right. This is the first patient we've ever used it in St Francis. I think there's only one other hospice in the country that has used it before. I can't even imagine what it will be like to try and do this at home because you have to have 2 pieces of kit. There's a 99-minute drying cycle every day for each individual piece of kit. It's really quite labour intensive. I think if it goes wrong and you're not in a healthcare setting, that is very, very scary. So, this is very new, and I think we are going to have to come. Miria and I are planning to meet to try and talk about what the indications might be and when we might use it, and also to know when not to use it. And I'm having those conversations with the hospital physicians as well. So it's new. It's fantastic for some patients. But let's not forget that many patients actually will be better managed on syringe pumps with morphine and midazolam, even if that means we have to deeply sedate them while they're dying. I just wanted to, Optiflow is not going to be a panacea.
Thank you. Maria, one last question before you head off. What is the maximum flow you would recommend through nasal specs? Is flow rate more important for those patients than FiO2?
So, flow via nasal specs isn't an FiO2. So an FiO2 is only really coming from a Venturi mask. So if you're doing litres up the nose, it's 1, 2, 4, 6 litres. What that FiO2 translates to is debatable depending on your own respiratory rate and how much you dilute it. So just to be clear on that one. But to be honest, people say, maximum of 4 up the nose is the only thing that you can tolerate. Well, we all know we've done more than that. And I think the patients have had more than that. But Sharon's right. You get crusting, you get bleeding, it's dry. So, I'm not going to set a maximum limit of the nasal specs flow rate. Clearly, I think once you start to get into above 4 and certainly below, like up to 6, 7, 8, and I've even probably had someone saying I put 10 litres, but that's like a hurricane up the nose. Your eyes are rolling at this point. So I think you have to, it's very drying, and surprisingly 60 litres up the nose with the Optiflow is incredibly easy to tolerate. So it's incredibly different how cold, dry oxygen, you can't tolerate more than 6, 7 or 8 litres probably, but 60 litres up the nose with nasal specs with an Optiflow is a breeze. So it's all around the heated humidification system that makes it more tolerable.
Yeah. And there's also if I'm correct, you can get wide bore nasal specs, can't you, to tolerate more oxygen?
You can, but I still think it's not wide enough, put it that way.
Still 6 is
still
as
pretty
high
much,
as you want to go.
Yeah.
Thank you so much. If there's any other questions later on in the talk, we can try and answer answer them on your behalf or ask you later. Thank you so much, Maria.
Bye. Bye-bye,
Take
everyone.
care. Bye.
Bye. Great talk so far. Thank you very much. It was really